Welcome to Medspectives, the podcast about health professionals, the stories of their practice, and the diverse perspectives into the world around us. I'm your host, Arvind Rajan, and on today's episode, we're joined by Dr. Hudson Garrett. Dr. Garrett has an extremely diverse background as he not only works as a paramedic, but also has a Ph.D. in healthcare administration and is an assistant professor of infectious disease at the University of Louisville School of Medicine. These diverse perspectives enable Dr. Garrett to understand medicine from not only a clinical viewpoint, but also from a health policy standpoint. He shares updates regarding COVID, including the issue of vaccine hesitancy that's going to arise in the next couple of months. Dr. Garrett also has an entrepreneurial spirit and shares his time as the CEO and founder of the Community Health Associates, as well as his time in his nonprofit. He discusses stories from his years working in EMS, and all around, Dr. Garrett has a lot of other insight into healthcare. I hope you enjoy, and if you like this conversation, please drop a like below, subscribe to the channel, and check out our other episodes. We're also found wherever you get your podcast. On with the episode. Glad to have you here, Dr. Garrett. How are you doing today?
I'm good. How about yourself?
I'm doing fine. Thank you so much for your time today. I know you're really busy, but I really appreciate you took the time out of your schedule to meet with us. I just want to talk to you first about your journey into medicine. I know you're a paramedic and you're in emergency medical services and you're doing a lot of other interesting stuff. So how did it begin and how did it kind of progress through your career?
I started when I was quite young with a fascination with first aid kits, to be honest. Always was interested in medicine as a child, and then in high school became a certified medical assistant. Worked throughout that time period, and then worked for a community college teaching EMS professionals for quite a period of time. Still do that to this day, and then decided to go in and become a nurse practitioner. And get my doctorate. And so I really enjoy a diversity of different activities. I don't like to be bored. And so this sort of pathway has afforded me that opportunity to teach, to clinically, work in the field, but also to help advance policy, which I think is an important part of what we need to do in healthcare today.
Right. And I really am fascinated by the breadth of your experiences, right? You not only have the direct clinical patient care aspect of it, but you also have that broader, healthcare administration aspect of it too with your PhD. And then again, you're working on policy as well. And it's really interesting to see, all of that in one person because like you said, medicine is such a large field and it's so important for all those different parts of it to come together. And I think in politics especially, and in the field, you need to have people like yourself where you not only know the policy, but you've actually been there to treat patients. And so how has it been translating those clinical experiences that you've had into working in policy? And I know you are one of the main members of the COVID-19 response team in Atlanta. So how has that whole process been?
Well, there's so many things that on paper look great, but you can't execute them on an ambulance or you can't execute them in an emergency department. Luckily I have a very good relationship with the CDC and have brought a couple of those matters to their attention. And as always, they're good partners and have made accommodations to try to either clarify or strengthen certain language to make sure that we're keeping our healthcare team safe. Because I think one of the things that has been, at least for me, particularly challenging is that this is a virus that's highly transmissible. And unlike Ebola, where there was a very limited chance that you as an individual provider would be exposed to it, with COVID, you're exposed to it every day and you just don't know it. And so there's a lot of people walking around without symptoms. And so, part of the policy role has to be to make sure that what we say is, needs to be done can actually be done in every single practice setting and can keep our providers safe. And I think that's an important aspect. We don't really focus on policy a tremendous amount, especially in EMS as we need to. But this is an important aspect of making sure that we have that right seat at the table. And that's why I really enjoy straddling sort of the EMS pre-hospital side of the fence as well as the hospital side. And I also am a professor at an academic institution, and that gives me a different lens to look through that helps from an educational standpoint.
Right. And I know you do a lot of work in infectious disease and like the prevention of transmission. How has that, that education that you've had really, I guess, come to the limelight, especially with COVID?
Well, normally when I tell people I do an infectious disease work, they run in the other direction, and now
Yeah.
they're asking more and more questions. So suddenly there's this direct interest in my field, and the same is true for our hospital-based colleagues that do infection prevention and control that have been there for 20 plus years, that have been unrecognized in many instances, and now suddenly there's an interest in trying to stop the spread of these infections. And I hope that we use this as frankly a wake-up call to say this has got to be a hardwired process that we do every single time. But I will say that I've seen some horrific infection control practices, both in the pre-hospital and the hospital setting, that need to be fixed, and they need to be fixed yesterday. Because if not, we're going to have a very poor readiness for future pandemics or infectious disease threats. And we know, history tells us that we know we'll have another one. Whether or not it'll be a global pandemic or more of an epidemic, that remains to be seen. But we've got to fix some of these low-hanging fruits, like our core practices, like hand hygiene and disinfection of surfaces, and appropriately wearing personal protective equipment.
Right. And it's really interesting to hear, like, I was talking to an emergency medicine physician a little while back, and they were talking about how it was, sometimes in EMS, like way back in the day, it wasn't, people didn't even wear gloves all the time.
Yeah.
And then now it's becoming, the masks are becoming like required, or they are required. And then in the future, maybe after COVID, that might also become a standard part of PPE for some kind of, that kind of treatment. And it's really interesting to see how that develops.
Well, I mean, even now when masks are required, I can go in 90% of hospitals and see people not wearing masks. Or they're pulling them down, or they're down below their nose. And my favorite conversation these days is your nose is part of your respiratory system, which is connected to your lungs, which is where COVID lives. So, we're not doing ourselves any favors by not following our own recommendations. So, what that new normal looks like in the future, I'm not sure. Do I personally think that we'll be wearing masks for years to come? I don't. I think that will certainly be part of our arsenal, but I'm very optimistic about the upcoming vaccine releases. Our next challenge is going to be to convince people to get the vaccines, and that really honestly starts with us as healthcare providers.
Right. And you're doing a lot right now, yourself personally, like you have helped a lot in, spreading awareness about um, this pandemic and information, disseminating information about that. What are your, I guess, personal goals in trying in the future of this pandemic of like what are you trying to, I guess, accomplish and bring to the table in these next, in this next year?
I mean, I think that's a good question. We've really shifted from our initial, oh my God, response to now we have a better idea of the transmissibility, the routes of transmission, how to stop it. We're in a much better position now, thankfully, with personal protective equipment. Sort of our next big hurdle that's really going to kick off around sort of the Christmas, first of the year timeframe is frankly the vaccine. And there's going to be a lot of vaccine, what we refer to as hesitancy, where we know that 1 in 3 people are not trusting of the vaccine process. They don't understand how a vaccine could have possibly been developed in this record amount of time. And that's understandable, but unfortunate because there have been no steps skipped in the vaccine process. They've only been accelerated and many done in parallel. And so when we think about how do we make sure our workforce is safe as healthcare providers, it is the vaccine, just like with the flu shot. And yet we have still a low compliance with the annual flu shot, and we see a lot of employers that make that mandatory. So really my focus for the next year is going to be a lot on overcoming some of those hesitancies, making sure that we're looking at, frankly, some retrospective analysis of our bad practices, and to really sort of operationalize like things like the burn rate calculator that CDC has published to help facilities be prepared for PPE shortages. There's no shortage of tools. What there is a shortage of execution and strategic thinking, and we've got to do a much better job of that. And everybody's excuse is, well, I don't have the time. I get that, but sometimes you have to make the time in order to prepare for the future, because what I think we would all agree to is that we can never go through what we've been through as a healthcare system and frankly as a society with COVID-19.
Right. And it's really exciting to, I guess, on a positive note, see like how much of a wake-up call this whole pandemic has really been. And, if we can turn that into sort of like getting prepared for the future and making sure we don't go into that again. I also am curious to know, like, with your initiatives with, like, for example, the Community Health Associates that you founded and are now the CEO of, as well as the Infection Prevention Institute that
Mhm.
is your nonprofit.
Yeah.
What were your goals when you founded them, and how have they kind of developed as your time with them has grown?
So I really have an entrepreneurial heart. I like to do new things. I like to build new things. I like to see people grow. I like to see success. One of my biggest things that I love in healthcare is to have a connection with the patient, which, unfortunately in emergency medicine, you don't get. In infectious diseases, you normally don't get. And frankly, in EMS, you don't get. And so I use this as sort of my conduit to build long-term relationships with clients that are mostly healthcare providers. I deal a lot also with public safety, so I partner a lot with our police departments, our fire departments, and EMS to deliver the life-saving education that they need in order to keep their communities safe. But I try to do it in a unique way that is customized for what they need. So for example, if you take a firefighter who is a paramedic and they work 24-hour shifts and they only have 2 days off and they work a second job, it's not really feasible to put them in a classroom for 16 hours to renew their
Right.
pediatric advanced life support. And so we try to come up with good customized ways through blended learning and other techniques to make it reasonable and tangible for people to achieve their goals. So that's sort of the community health associate side of the house. And then on the nonprofit side of the house, a colleague of mine and I started this with a goal of making sort of open access, free range education related to infection prevention and control. And so now we're engaging in a project actually with the CDC to bring frontline healthcare education to nurses and EMS providers and long-term care professionals on basic infection control. Because, like I said earlier, COVID-19 has taught us a lot clinically, but the difference in my mind between this sort of pandemic and anything we've gone through in the past is the financial implications. Never has healthcare been decimated. Never has society been literally shut down like it has been with this. And so, that sort of works advantageously to the conversation because people will agree, regardless of what side of the aisle you're on, we don't need to shut down again because we can't afford to. And so we've got to figure out ways that we can operate within a safe context without jeopardizing either healthcare providers or patients.
Right. And it's interesting, like you are using like online platforms a lot with these kind of things. Is that kind of what you're talking about with how you're going to do these, like make these, I guess, prevent people from having to sit in like 16-hour classes or things like that, is, adopt online platforms like that?
Yeah, and I think online is probably a loose term. It needs to be highly engaged, interactive experiences. And so when I think of a good example, like the American Heart Association has partnered with Laerdal as an example to create these simulations for basic life support and advanced cardiac life support and PALS that really are competency driven. So as you sort of succeed, it accelerates your progress. If you need additional remediation, it slows down your progress, but it brings sort of custom scenarios that are based on real life events that you as either an EMS provider or nurse or physician would face. And I think that that's really got to be the future of what we do. These sort of old days of when I went to school and they pop in a video
Right.
and the instructor would stand off to the side and, those were god awful.
Yeah.
And they don't work. And yes, they were consistent. I mean, you can't say they weren't consistent. The videos did show the perfect elements of CPR, but that didn't work when my patient was underneath the dining room table and I had to pull them out and they had a C-spine precaution.
Right.
So, these are all things that we've got to do a better job. And I think if there's one thing that sort of jumps off the paper at me is a lack of critical thinking in healthcare. We have to do a better job of imparting these skills in our students as they come out. And that's a really hard thing to do. And it's a delicate topic because if you tell someone who is extremely book smart that they're not good critical thinkers, they become offended. And in reality, the best practitioners in any healthcare environment are those that have the ability to critically think and don't, rely strictly on the algorithm that's published. And I
Right.
think that that's a needed thing that we've got to teach students how to do a better job of mentally.
Yeah, and I completely agree with what you said, like with the video aspect of it. Like I know, whenever I do like HIPAA training for something, like it'll be like online modules that, watch a PowerPoint and then take a quiz on it, but I can go back to the PowerPoint to pick out things. And I really, really like what you said about the interactive, and I think that would be a really amazing thing where you have like actual, I guess, case studies of when these techniques would actually be applied, because I feel like that's, like you said, ultimately how you learn.
It is, and learning is so customized. I mean, I start every class I teach with, "What do you want to learn?"
Right.
And people are always surprised, and they say, "Well, why are you asking that?" And I just need to get the card. And I said, if you only need to get the card, you're in the wrong class. If you want to learn the material in order to save a patient, then you're in the right class. And I think that, there are absolutely those people that just sit in a class because they have to, and I hate those people, because they don't get the experience that we're there to create. And there are lots of instructors that will give cards. That's just not something that I'm interested in. I think that we have a moral and an ethical obligation to give our absolute best to our patients, and that starts with having highly competent personnel that are responding to the scene.
Right. And what motivates you to do that, right? What motivates you to teach all the students that you do, whether it be in EMS or infectious control or in whatever, in the wide breadth of things that you do teach? What motivates you to keep doing that?
The absolute massive opportunity for improvement that we have in healthcare. Every single day, I'm terrified of what I see. And I realize that as I age naturally, just like everybody, that these people will be taking care of me. And that terrifies me. And so I have to do something now. I really enjoy educating. I'm actually a terrified public speaker, which people are always surprised by given the number of lectures I give each year. But I bring everything to the game. I leave it all on the stage, and it's important to me to give my very best. And I expect people that are taking care of patients to give their very best. And I think this pandemic has caused us to have what I like to call the emotional resilience bank account deficit, because we have made so many withdrawals through overtime and PPE usage and time away from our families, and being held over after shift, or just very sick patients, that we've made very, very little deposits that bring that emotional bank account back to the positive. What I'm very concerned about, and I did mention this earlier, was, you said, what are you going to do in the next year? And part of that answer is certainly, vaccine hesitancy, vaccine education awareness. But honestly, I think the other piece has got to be, we've got to make sure we take care of our team. Our teams are hurting, they're damaged, they're broken, they're tired, they're exhausted. And we have not dealt with that. And so those sort of effects of, healthcare PTSD are there. They may be, underlying. It's sort of like peeling the layers of the onion back, but they will rear their ugly heads if we don't deal with them. And we need to start dealing with them now.
Right. And it's weird to see, like, in the initial wave of the pandemic, over the summer when it was very serious, we were, hearing these stories from healthcare professionals of like how terrible like things are going.
Mhm.
And then it feels like there's actually like a period of silence when actually cases are going up, when, the reality is it's still happening. Like all those crises are still happening, but we're not hearing from it as much. How do you think that aspect works in where the same stuff that was happening over the summer is still happening, but I guess we're just not giving it as much attention?
So I would challenge that a little bit and say that we're not having the same level of crisis
Right.
that we did. I can tell you that from firsthand experience. I mean, when this was really bad, I would go into the emergency department and there would be 15 patients in front of us, all with COVID waiting for rooms. You would see multiple different rooms converted to isolation. You would see ICUs full of patients on ventilators, prone, upside down. We're not seeing that.
Right.
By no means am I saying that we're not seeing COVID patients. We absolutely are. The good news is the sort of overall mortality of the virus has dropped substantially, which is good. We're seeing less, cases that require hospitalization, which is good. And I always caution people on strictly looking at the number of cases that are positive. So if you look at the overall positivity rate, it's actually been fairly constant in the US. with a few weeks of exceptions where it would go up or down a percentage point, which is not substantial. But I sort of look at a couple of factors. One is how many total number of cases are there, which honestly is on the very low end of the totem pole. Number two is how many of those people require hospitalization. Number three is how many of those people die, right? What's sort of that overall mortality rate associated with those patients? And the fourth one is what are my available healthcare resources to care for those patients? So, and that's not just physical resources like ventilators and beds, it's equally properly trained personnel, right? To have enough respiratory therapists or registered nurses that are critical care specific, those types of things. And there are places like Utah comes to mind where they are in crisis mode, where they have not enough ICU beds. Now they have enough supplies, so we're in a much better position. We have enough PPE. We certainly have an excess of ventilators. Thanks to the administration, we've gotten a lot of the remdesivir and some of the other medications, and we're very thankful for that. So it's a different level of crisis. I think now we're seeing this spike in cases that's alarming people. I expected it. Because especially as we're doing more and more testing in the community, we're going to see more cases. What I don't freak out about is the total number of cases. I get very worried when I see a massive increase in hospitalizations. So like here in Georgia where I live, we've seen obviously a very proportional number of cases, just like the US has seen. Our hospitalization rates have been fairly constant with a few ebbs and flows, but by no means are we overwhelmed. By no means are our resources exhausted. Our personnel are exhausted, but our physical resources are not.
Right. And it's interesting to see because like you said, when we look at the numbers, I think one of my concerns originally was you see like an increase in cases, and like you said, that can be highly like attributable to the increased testing.
Right.
But then you don't see like the death rate you were seeing with that high level of cases
No.
as compared to the summer. Is that kind of just because we're testing so much, or are there like is it like the hospitals are better used to treat those kind of cases and they have the right protocol in place, or what exactly or how exactly are those death rates lower than we
It's
saw?
a combination of things. I mean, when you look at viruses that last this long, they're not going to maintain normally the same level of mortality as they had when they first. So if you think about it in sort of terms of waves, the first wave was let's go attack the most vulnerable people, right? Our long-term care residents, our immunocompromised persons. And it did that. And it did that very successfully. And now it sort of came back as another wave to go after that next, sort of round of people. But every time it does that, especially when the host doesn't die, it loses a little bit of its potency. And so we've certainly seen that. That being said, we've also seen highly effective treatments like remdesivir, convalescent plasma. Certainly we're getting people off ventilators or not putting them on ventilators, which is very helpful. The initial thought when this all hit was put everybody on a ventilator, turn them upside down, let the fluid come back out, and hopefully everything will be fine. And the data didn't support that. So now we're doing high flow nasal cannula, CPAP, BiPAP, all kinds of other interventions to try to keep these people out of the realm of invasive ventilation. And so it's really all about data. And people always are complaining to me. They're like, well, why do y'all change the recommendations every single week? And I thought, aren't you interested in evidence-based practice? Evidence-based practice means evidence, right? So as we have more evidence, we change the practice. And that may change every week. So yeah, I understand it's frustrating, but the majority of the CDC's core recommendations, with a few exceptions, have really not substantially changed. Probably the biggest one that's caused a lot of issues here lately is the term of airborne transmission that was sort of publicized out there. And with a few exceptions, that's been one of the biggest ones that's come up.
Right. And I think it'd be interesting to talk about your experience in the pre-health or pre-hospital setting as a paramedic. So you deal with patients, in this kind of setting. How often do you see, I guess, COVID cases when you get phone calls asking for the paramedics?
When this was bad, it could be in a 12-hour shift. It could be half of our patients or higher. Yesterday, it was one patient. Normally, it's 1 to 2 right now. It just depends, but again, that's spread out across, about 30 different crews over the course of a day. But we get, my crew that I work with and my partner, we tend to get most of the COVID patients if we're available. So it really just depends. We also deal with some chronic COVID patients that are, going back and forth between different types of facilities to receive specialized treatment. So it's not just the acute care patients, but it's also those that are on chronic O2 and things like that we have to deal with also.
Right. I'm curious to know more about those chronic patients that you're talking about with COVID. So um, is it like they have symptoms and they kind of, go away a little bit and they can go home and then it kind of gets worse and they got to come back, or how exactly are those chronic patients doing?
It depends. Everybody's a little bit different. I've seen patients that have had no chronic issues at all, and I've seen others that have had, months, 6+ months of chronic conditions. And the literature is just now starting to emerge from those types of patients. And there is a large proportion of patients that have, what we would really consider permanent disability, whether it's the constant need for oxygen or, long-term taste or and smell issues. Patients that have sort of that mental fog and fatigue is another common one that we see. So I don't know if we've had enough time. I mean, it's only November to really fully appreciate what that looks like. But I think it's safe to say that the majority of patients do experience some type of lingering effects. A lot of times it's a cough or some acute shortness of breath. It really just depends on what else you've got going on. Because remember that COVID attacks the most vulnerable aspects of the body. So if you are already a COPD patient, then it's going to go say, hey, great, I'm going to go attack the lungs. Or if you're diabetic, it's going to attack the brittleness that you've been maintaining your diabetes. So, it really just depends on what the patient sort of already brought to the equation and to the table up front.
Right. And that's really concerning to see. I mean, we've always known, right, that those pre-existing conditions are like the most vulnerable COVID patients.
Right.
And just kind of talking more broadly about your time as a paramedic, what are some cases, we love telling stories on the podcast. What are some cases that, you hold dear to yourself or you find, very important in your career over the years as a paramedic?
I mean, that could be anything, but as it relates to COVID, I think it's the fact that families are separated from their loved ones. And, all too often, and this just happened a few weeks ago, we pulled into the ambulance bay and I looked across into the ER parking lot and I saw this very large group of people. And my gut said, that's that patient's family that we're going to get. And so we went inside, got the patient, we were taken into a higher level of care, and we came back out. And I see all these people intently watching this patient, and I knew it was their family. And the patient had been in the emergency department for a day and a half, not seeing their family, had not seen their family at all, had not talked to them, had no idea what was going on. And the patient was most likely not going to survive. And so, the hospital did not make the accommodation to at least let some of the families in, family members in, and there are safe ways to do that. And so we decided to make that accommodation to give them all masks, allow them to come over, at least, put their hand on their relative and let them know that they loved them, let them know that they were there. And, I think that that's what you can't teach in school. That's not something that's in a textbook. It's not something that an instructor can teach you. It's simply a matter of just being a human being. And I think COVID has taught us so much about we can't lose that, even though we're wearing all this PPE. Because patients can't see our smile, they can't see our frown, they can't see our emotions, they can't see anything about, all they're seeing is that. And when we're taking care of COVID patients, we've got on full face shields and hair nets and gowns and all this other stuff. And so little things like, putting a picture of yourself with your name. Hi, my name's Hudson. So they know who you are, and they can communicate with you. It just makes a big difference because, these are people underneath the patient gown that they're wearing. And I think that that's probably one of the biggest things that we've had to learn.
Right. And I think people, when they call 911 or, they have to call emergency medical services, like that's the last thing they want to do. And they're doing it because that's literally all that they can do. And, now they're looking at people that, like you said, they can't even see. and they're putting their entire life in their hands. And how is that feeling for you? Like that feeling of like, you are all that the patient has in terms of, in that moment.
I mean, I would say it's an immense responsibility with very little, if any, respect given by most people. It's rare that EMS is ever told thank you. It's very rare that EMS is ever made aware of how the patient's final disposition is. It's very rare that EMS is ever allowed to sort of interact and see what happens at the hospital. And that's, again, one of the reasons why I like to be on both sides of the house. I like to make that bridge. And that's the reason I still practice in EMS. I mean, most people say, well, why would you practice in EMS with a doctor? And I thought, well, why not? Like, what makes me any different than anyone else? I think it only makes me better qualified to be on a truck. And hopefully also as a conduit to make sure we have better providers in the field. And frankly, we can have better respect in the hospitals. And so I sort of use that always as a great opportunity to remind ourselves that, we need to do better about interprofessional communication too.
Right. And you as a person are an example of like, interprofessional, you do the paramedic side of it and you have, like you said, the doctorate, which is
Yep.
really interesting, like to see that kind of connect. What kind of things have you been able to do, I guess, to address this issue of like this disconnect of, different fields of medicine?
I mean, I take it one case at a time, and I try to bring people to the realization that we're all part of one team for one patient, and the patient deserves one thing: patient safety. And that requires an adequate handoff and transition of information that's relative. Just last night, it's very common for me to have registered nurses with master's or bachelor's degrees not even be able to tell me basic information about patients. That's not acceptable. Just like it's not acceptable for an EMS provider to roll into the emergency department and not be able to tell basic information about the patient or the interventions that they took. Now, obviously, if the patient's unconscious when we arrive and we can't determine that information, that's different, right? But we have to do a better job of knowing what we're doing and sharing that information. And I get that the stressors are massive, but we can't afford, the difference in healthcare in my mind, especially in EMS and in emergency medicine, I think, is that you can't afford to have a bad day. If you have a bad day, patients could die. It's very, very different than if you're on a med surg floor or something like that, where the risk is much lower. But if I don't intubate that patient, or if I don't give that patient fluids, or if I don't give that patient nitroglycerin, there is a negative consequence that might be suffered by that patient that may be irreversible. And so that's a massive responsibility that, I think in a lot of ways is daunting, and it always sort of humbles you, or should humble you, to think you have that knowledge and that training and that power of recognition, but you also have that authority. And I think that's honestly one of the things that's so different about EMS providers that especially ER nurses don't realize. Like, when you're an ER nurse, yeah, you're an integral part of the chain and you're a great resource. But the difference is you have every resource at your disposal. You press a button or you call somebody on your phone and a whole team shows up. And you've got ultrasound and you've got x-ray and you've got labs and all this other stuff. And we don't have any of that in the pre-hospital setting for the most part. And so I'm always amazed when ER nurses were like, well, why didn't you get an IV? Well, because I was going 75 miles an hour trying to get the patient here and they were fighting me and I was trying to restrain them and give them medication and get them here safely. Do you have any other questions? Right? So it's a little bit different than when they can restrain them a lot safer versus being in the back of a moving box where you have very limited capacity.
Right. And it's really interesting you say the responsibility aspect of it, right? You have the fact where you have this immense responsibility, but you don't have the recognition for it.
Yeah.
You're expected to do all these things, because of course it's your job, but it's always nice, I guess, whether it be from a patient or by like, whatever hospital or organization you're part of, to get some kind of recognition, because at the end of the day, we're all human. And I think that's a really interesting thing about emergency medicine and the pre-hospital setting in general, is that you have these like priceless responsibilities, but you don't get the, I guess, recognition that you would normally expect from something so important in society.
You don't. And I mean, I was joking with a good friend of mine that's actually an anesthetist. And he said, and he was serious. I was just shocked by this statement. And he said, well, I don't even remember how the conversation came up, but we were talking about somebody with an asthma attack. We were joking because, of course, anesthesia is considered the intubation experts. And I said, yeah, you are. But I said, you intubate well in a hospital where the patient's on a stretcher and they're in a perfect position for you. You don't intubate with them sitting up or in a car with a seat collar on or upside down or all these other things. And we were joking and he said something about, well, an asthma attack. And I said, yeah, we would give albuterol or Atrovent or some of the other stuff we have, racemic epinephrine. And he sort of stared at me and I said, why are you staring at me? And he said, well, I didn't know you had that on the ambulance. And I said, you must be kidding me. I said, so you think you call 911 and we put you in the back of the wagon and we just drive real fast to the hospital? And this is somebody with a doctorate. And he said, well, I didn't honestly realize that all that stuff. And so I think there's a misconception, certainly with the public, but even with other people that we work with on a daily basis, that EMS is nothing more than a glorified, boo-boo bus. And, it's unfortunate because, the stuff that we do is very much in line with what's done in most emergency departments. The difference is we're not doctors and we're not doing it, there's not a doctor telling us to do it right then. And so, whereas our ER colleagues that are ER nurses, they have to go get an order. We already have the orders. It's up to our eyes and our recognition and our diagnostic skills to say, okay, this patient has a tension pneumothorax, let's decompress it. That's not done in an emergency department. It's done by the physician or the nurse practitioners or the PAs. So it's just a very different environment. One's not better than the other. They're both complementary. But I think we need to acknowledge each other's skill sets. And that's why I think we see a lot of emergency departments that are hiring all the paramedics out of the field that they can, because they know that the paramedics bring a very unique skill set to the emergency department.
Right. And I guess that kind of leans into this question, but what is something that you wish people knew about your field as a paramedic?
I mean, I think I wish people had a better appreciation for the amount of training and skills that EMS providers go through. I on the other side of that, also wish EMS providers took the role more seriously. There are many that, when you come up to a scene and your shirt is hanging out and it looks like you've never shaved or you've never brushed your hair, or you don't smell good, these are all things that are not acceptable. And so there are a lot of things that are done in public safety that do not help our cause. You will not see that for the most part in the emergency department, right? You will see people that are professionally dressed in scrubs, or their t-shirts that are hospital issued. It's just a different environment. And so my always challenge to our field is, if you want to be seen as a healthcare professional, you must act like a healthcare professional. You must treat yourself like a healthcare professional. Don't be out in the ambulance space smoking, and don't be, speaking in vulgar terms or unprofessionally, right? Even if it's just you and your partner, there's always somebody watching. And I know that happens in every healthcare environment. So I'm not just isolating EMS, but there's a high bar for excellence in EMS because we are doing things on our own, and it's a very mobile environment that has a lot of autonomy. And with that autonomy, I think comes a lot of responsibility. But we've got a better job to do of educating the public about what we do. And I think that starts with community education, and giving people a better understanding of, when you call 911, here are all the things that can happen.
Right. And I guess before we close out, I just want to ask you, what are your goals in life, right? As you're doing all these things to, better the people's understanding of interprofessional communication and infectious control. How do you see your future in, I guess, integrating all these things, and what is your kind of vision of what you want your impact to be?
My thing, as cheesy as it sounds, is to have a world without healthcare associated infection. right? I can't control every single infection, but I can certainly control the ones that we give you in healthcare, right? You shouldn't come in for an elective knee procedure and leave with an MRSA infection. Like, that's not acceptable. We can control that when we put you on a ventilator, that you should not get a ventilator associated pneumonia. We can control that you should not have dirty surgical instruments used on you and contract an infectious disease. And so that's really always been my area of focus. What I would love to see is a high compliance with what CDC refers to as the core practices of infection prevention and control, things like hand washing, PPE usage, proper vaccination, those types of things. If we can get to that point, if I can help be a small part of that in my career, then I will feel very satisfied with that. Because, if we were to just do the core practices, CDC estimates that between 80 and 90% of our infections that we see in healthcare would simply go away, right? And that's a very powerful statistic to think about. And none of the stuff I'm talking about is expensive. It's not time consuming. It's not hard. I can teach somebody who is a sixth grader to do this stuff. So I can certainly teach a licensed, educated healthcare professional to wash their hands, right? And it's all about accountability. And only through that will we get to a place where patients are not fearful of their hospitalization, or they're not fearful of their interaction with us in healthcare. And I'll sort of close with a quick summary of a story. So when COVID all hit, we received a phone call from a hospice organization, and it's a very odd phone call. And they're asking all these questions about how we clean the trucks and things like that. And then I finally said that they actually asked me to talk to this lady, because the dispatcher was saying, I can't figure out why she's asking all these questions. And they knew with my background, I'd be able to answer them. And I asked the nurse, I said, is your concern about COVID? And she said, yes, sir. She said, we've got a patient that's very, very ill, that's on hospice, that's not going to survive much longer. And we just don't want to expose that person to COVID. Can you give us an ambulance that's not had COVID in it? And I'm sort of laughing in my head, and I'm thinking, no, because every one of our ambulances has had COVID. And she said, well, can you find me an ambulance in the state of Georgia that's not had COVID? And I said, no, ma'am, I can't. I said, because every ambulance has either had confirmed COVID or suspected COVID in the ambulance. And so I walked her through what we did, even offered to show her the process. And she was so blown away with that. She's like, okay, I feel much more comfortable with you than anyone else we've called. Can we have you as the crew? And so it's sort of like a request. And so, these are all things that normally would not happen. And I work for a private EMS agency, so it's a little bit different. But, sometimes we have to take the time to make our clients, right, our customers and our patients feel much more safe and at ease. And COVID has made people feel very scared. And so I always try to do a good job of making people see that. And when they see me roll up with my full respirator on, and I'm always wearing safety glasses, yeah, I may look like Darth Vader, but they know that I'm taking it seriously, and they know that I'm protecting them. And I make them wear a mask. And so these are all basic things that we can do.
Right. And it's really, it's amazing to see like how the basics are the most important thing, right? Like
Totally.
we learn all these like, as your medical education goes on, you learn about like these really complex stuff. And I guess it seems like you kind of forget the most important stuff, like the basic stuff. And at the end of the day, that's what really comes back and bites you in the butt.
I mean, there's a reason it's called basic life support, right? Because it is life support. And even working a code, if I just do great CPR and great ventilations, and I get an AED attached, my outcome is probably just as good, if not better, than ACLS interventions. If I get it started early. So we've always got to think about going back to the basics, and every EMS provider has always got to think about being a great EMT first. And I think that's really hard for advanced level providers to think about, because people get offended and they're like, well, I'm a paramedic. And I'm like, I don't care. You're still an EMT, right? You're an EMT at your core, and basic life support always supersedes advanced interventions, right? If I'm not doing chest compressions, it doesn't matter how perfect my IV is, because I'm not able to circulate that medication. And so I think we've got to be humble about that, and remember that we've got to always get back to the basics.
Right. And thank you so much, Dr. Garrett, for all your insight.
Sure.
I really, really appreciate your time here today. And I just want to thank you so much for coming out to the podcast.
Awesome. Thanks for the invitation.
I hope you enjoyed listening to our conversation, and thank you so much for listening. If you love Perspectives, be sure to follow us on Spotify, drop us a review on Apple Podcasts, and share this podcast with your friends. It really helps us grow, and I'd really appreciate it. Thank you so much, and I'll see you next Monday.